This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended.
How do we place a multipiece intraocular lens into the sulcus when we have a large posterior capsular tear? Hello friends, this video is all about that. Now we have a situation in this case. A large posterior capsular tear is staring at me. The rhexis is intact. When we look at the shape of the rhexis, now this line delineates the extent of the posterior capsular tear, and we have a second line which probably hints at the rupture of the anterior-hyaloid face. There are certain telltale evidence suggesting the prolapse of vitreous. One obviously is this ruptured anterior-hyaloid face, and second would be also when we look at the posterior capsular tear. The posterior capsule seems to be wrinkled and is pushed towards one side. And what is pushing it? It's probably the vitreous which is prolapsed out and is pushing this posterior capsule towards one side. So these signs are suggestive of a PC tear along with the vitreous prolapse. So obviously the first thing to do is to do an bimanual anterior vitrectomy. Now to begin with, I have not used triamcinolone acetate simply because it was very obvious to me that the vitreous is already present. The irrigation cannula is in my left hand and the cutter is in my right hand. They're gone through the two paracentesis incisions which we make for our bimanual cortical aspiration. So let me just share the settings here. The cut rate is around 4000. The vacuum is set around 350. But mind you, I'm beginning with a very low bottle height. It's about say 38 or 40 centimeters. And as the vitrectomy proceeds gradually, my goal is to increase the bottle height. I begin by holding the cutter turned down posteriorly and then I begin my anterior vitrectomy. As the vitreous is being cut, we can see that the area of the posterior capsular tear decreases as the vitreous which is occupying the space decreases, and the edge of the posterior capsule moves more towards the cutter now. The vitrector is then turned sideways to clear off all the vitreous which is around the vicinity of the posterior capsular tear. The port of the cutter is finally turned anteriorly to cut all the vitreous which is there in front of it. So now we can see that the posterior capsular tear which was splayed sideways initially, the flaps are now coming closer, but nevertheless it's an equatorial extension of the posterior capsular tear. So there is absolutely no scope for placing the lens into the capsular bag. So my mind is now working on placing the multipiece lens into the sulcus. In the event of a posterior capsular tear and a vitreous disturbance, for any lens to be very successful, the most important criteria is the absence of vitreous in and around the capsular bag. That is the prerequisite. So I cannot emphasize how important it is to have a functioning vitrectomy unit and a cutter when you're faced with such a crisis. If we perform a good anterior vitrectomy and place the appropriate lens, invariably we find visual outcomes which are almost indistinguishable from a routine case. So the most important equipment for a cataract surgeon to have is a functioning anterior vitrectomy unit. So it takes a few minutes for the vitrectomy cutter to take care of all the prolapsed vitreous. And I'm going to trim a little bit of a posterior capsule so that the edge should not come into the visual axis. So I'm intentionally widening the posterior capsular tear just to ensure that we don't have the edge of the posterior capsular tear coming in the visual axis. The time to place the intraocular lens. Now let me take you through two challenges which I have while placing the lens in the sulcus. Number one is the pupil. Pupil is not very well dilated. It's hindering the visibility of the anterior capsular edge, especially in the opposite quadrant. So it's going to be a challenge to place the leading haptic over the anterior capsule and under the iris. That's one challenge. The second would also be the sizing of the rhexis. The rhexis is slightly bigger than what would have been ideal for a optic capture. It's about 5.75 but also a little bit eccentric. So achieving an optic capture with a slightly bigger rhexis is going to be a challenge. So two important tips here. Number one, I always prefer to use a cohesive OVD, that is sodium hyaluronate, to be placed in between the iris and the capsule. This I find it very helpful. It creates the space in between these two structures where the leading haptic has to be placed. And because it maintains the space well, during the maneuvering of the lens, there's a lesser chance that the haptic is going to slip and go under the anticapsule. The second tip would be to enlarge the incision before venturing to introduce the cartridge into the eye. The reason is the eye would be very soft when we have done an anti-vitrectomy, and negotiating a cartridge through a snugly fitting incision is going to be a challenge. So to ease this, it's always important to enlarge. Suppose I've used a 2.8mm keratome. I want this to be at least 3 or 3.1mm so that the 2.8mm cartridge can go in with ease. I'm having a second instrument, that is a Sulcus in my hand, which is stabilizing the globe as the cartridge is gently introduced into the eye. My left hand is retracting the iris so that I am having a clear view of the space which is present in between the iris and also the rhexis margin. So the leading haptic has to reach this space. But the problem which is happening now is the haptic is turned away. So I need to rotate the injector. So my second hand comes out of the eye. I'm using my second hand as well to rotate the injector so that the direction of the haptic is corrected. And then the eye is tilted just a bit so that I can get a glimpse of the anticapsular margin, and the haptic is gently threaded under the iris but still over the anticapsular margin. Once I'm certain that the leading haptic is in the ciliary sulcus and above the anticapsule, then I just use the dialer to dial in the trailing haptic into the sulcus. So the lens is very secure now with both the haptics in the sulcus and also the optic is above the anticapsule. Another common methodology which is used is to place the haptic first over the iris and then tuck it in. But if you're using a cohesive OVD, the space is very securely maintained and it's not so difficult to place the leading haptic over the anticapsule. The challenge is really when the pupil has come down, then that's a situation where we want to retract the iris with one hand to ensure that it is placed above the anticapsule. So maybe in that situation, you can always place it on the iris surface and then negotiate it with the forceps under the iris and above the anticapsule. Okay, now time to remove the OVD which is behind the lens. The irrigation is in my left hand, the vitrector is in my right hand. It goes under the lens into the vitreous cavity. And I'm just going to cut and aspirate all the OVD which is there and probably few of the vitreous fibers if at all they come out. And then the vitrector comes out into the antechamber and then removes all the OVD in front of it. So once I'm pretty sure that all the OVD is out, time to achieve an optic capture. With the irrigation still in my left hand, the vitrector is replaced with a Sulcus hook. The optic of the lens is gently tapped down, that is posteriorly. And I'm going to retract the iris. I can see the ovalization of the rhexis or the kink in the anticapsule, which suggests that the optic has gone behind the anticapsule. So in one end it is very clearly visible. In the second end, because the rhexis is slightly bigger in this quadrant, it is not very evident, but still we can make out that the optic is behind the anticapsule. Diluted triamcinolone acetate is used to confirm the absence of any prolapsed vitreous or any vitreous fiber remaining. Intracameral pilocarpine is used to bring down the pupil. These two steps, I do it just to ensure that I'm not missing out on any vitreous fibril. Sometimes in dilated pupil, it can be challenging to identify one single fiber, so this is one way of confirming it. The side ports and the main incisions are hydrated. That's it, the case is done. And these are the first day post-op pictures, and the patient usually does well. To summarize, when we are faced with a situation where we are supposed to use a multipiece lens, I think every cataract surgeon should be well equipped with both the knowledge and the instrumentation to perform an anti-vitrectomy, and also he should have handled the multipiece lens many times so that he can be comfortable during these crisis situations. So tip number 1 always would be to ensure that you've done a thorough anti-vitrectomy. Number 2 would be to enlarge the incision just a little bit so that we don't struggle in a soft eye when you're trying to introduce the cartridge into the eye. Tip number 3, use a cohesive OVD, that's sodium hyaluronate. We want an OVD which can create and maintain space, and it helps us to maintain the space, and we can easily negotiate the leading haptic into the space above the anticapsule and then also dial the trailing haptic into the sulcus. So that's one more tip. And to remove the OVD both in front and behind the lens before achieving an optic capture. And finally, once the OVD has been removed, with the still irrigation on in the left hand, using a Sensei, just tapping the lens posteriorly will ensure that we have a good optic capture. This ensures long-term centration of the lens, and because the lens is behind the intercapsule and in its physiological position, we don't have to do any undercorrection of the lens power. These are the key points which would help most cataract surgeons to place a multi-piece lens successfully in the sulcus whenever we're encountered with a large posterior capsular tear and vitreous disturbance. Thank you so much for watching and hope you found this helpful.